Good morning, good afternoon, good evening. I'm excited to welcome you today to our Vaughan Grand Rounds, today focusing on evidence for practice, non-invasive respiratory support. I'll be your moderator today. My name is Danielle Arrett. I'm the Asfa Yamaru Professor of Global Health and Associate Professor of Pediatrics at the Lerner College of Medicine at University of Vermont, and proud to be the Chief Medical Officer and Director of Global Health at Vermont Oxford Network. I'm joined today by three amazing discussants. We have Professor Roger Soll, Dr. Malette Abena, and Professor Michael Dunn. Roger Soll is the coordinating editor of Cochrane Neonatal and the director of the Vaughan Institute of Evidence-Based Practice. Dr. Abena is associate professor of St. Paul's Hospital Millennium Medical College and co-investigator and Ethiopian national lead for the African Neonatal Network. And Professor Mike Dunn is coming to us from the University of Toronto. Today we'll have talks by all three discussants, and at the end we'll have some time for Q&A. So please use the chat feature and we'll try to get to some questions. We'd like to thank our sponsors, the Vermont Oxford Network and Vaughan's Institute for Evidence-Based Practice. Professor Soll and I are disclosing our leadership roles at Vermont Oxford Network, and otherwise we don't have any conflicts of interest to disclose. So the topic today on evidence to practice is focused on continuous positive airway pressure. We hope that everyone joining in today will develop an understanding of both the strengths and weaknesses of evidence provided by systematic reviews and meta-analyses to inform the practice of neonatal perinatal medicine, as we have in all Vaughan Grand Rounds. And today we're particularly focusing on an important topic, non-invasive respiratory support, and specifically focusing in on continuous nasal airway pressure. We know that this topic has global importance, and we're curious to see where everyone is joining in today. So if you can use the Poll Everywhere feature, there are instructions at the top of this slide. You can either text or you can use the pollev.com/VT Oxford to answer this question. We're curious to see where everyone is joining from. It looks like we have over 500 participants joining in today. And although the chat feature is great for questions, the chatted in answers won't be reflected in our poll. So if you can use the website for this and the additional Poll Everywhere questions, that would be great. So it looks like we have quite a few from North America, but some also joining from Europe and Africa. And to mention that this session will be video recorded and on our Vaughan website probably within a week. So for those that have a inconvenient time of day, we hope that you can see this at a later time. And next, to kick off the session today, I'd like to turn over both the mic and the screen to Professor Michael Dunn, who will kick us off. Thank you.
Good day, everyone. I'm pleased to spend a little bit of time with you today talking about the use of CPAP for preterm infants and with respiratory distress. I'm going to be kicking things off, and then will be followed by my dear colleagues, Roger, Danielle, and Malette. My job is to talk about some of the basics in relation to CPAP. What is it and how does it work? And you can see the components of the talk in the outline. CPAP has been around for a long time. The first report of the use of CPAP in preterm babies with respiratory distress syndrome came from George Gregory and his colleagues from California in 1971. And this group appreciated that babies with surfactant deficiency and RDS may benefit from the application of continuous distending pressure to their airways in order to prevent atelectasis and facilitate gas exchange. Prior to this time, babies were treated largely with supplemental oxygen alone, although some babies had been subjected to mechanical ventilation. And with that, I think there was some babies who were able to survive after that, but many were left with quite significant chronic lung disease, as was described by Northway. So there was a need for a kinder and gentler approach to the treatment of this condition, and that's what this group did. You can see that they treated 20 babies with severe RDS with CPAP and reported on their outcomes in this publication. They used two basic methods to give CPAP to the babies. The one on the left shows that it was actually, they were treated with invasive CPAP through an endotracheal tube. Pressure was created through the flow and an anesthesia bag and a clamp. But on the right, there's a more innovative approach that they took, which was the use of really a helmet where the baby's head would go inside with a diaphragm tightly around the neck, and pressure could be raised within the head box itself and therefore thereby transmitted to the lungs of the baby. So they used both of these approaches in the study. And at the bottom, they show the outcomes. And you can see that in the smallest babies, 930 to 1500 grams, they managed to get survival of 7 out of 10 babies. And over that weight, only 1 baby out of 10 died. And this can be considered quite a success. These kids were all quite sick and would be expected to have very high mortality rates. This is a picture of a baby in the Gregory box. You can see the diaphragm tightly around the baby's neck and his head's inside. Pressure's being created in here and transmitted to baby that way. So although effective, you can imagine that this is really a rather cumbersome system and that they created some problems. Access to the baby was difficult. Things like feeding was problematic. And there was also problems with the diaphragm around the neck, with skin breakdown, and more importantly, a tendency to increase intraventricular hemorrhage. So from here, it was important that other methods of providing continuous positive airway pressure were developed. The next one that came online is really, it's shown here in this cartoon, but really it's just the bubble system with the Hudson prongs, which is a very simple system and one that is still in use today. And you can see that it's much easier to apply than the very difficult Gregory box. So this system came online and, as I say, is still being used quite widely. So how does CPAP work? Multiple mechanisms. Firstly, it promotes the recruitment of closed lung units. This is a little bit controversial in that CPAP does not ventilate and CPAP does not give any tidal volume, but it does appear that it may facilitate lung aeration, especially shortly after birth if it's applied to a baby who's trying to get their lung open in the first place. It stabilizes lung units upon expiration, allowing maintenance of FRC. This is probably the most important mechanism by which CPAP works. Several spin-offs from this are that compliance is improved as the lung is expanded rather than atelectatic, reduces the work of breathing, conservation of surfactant by having a well-expanded lung with less leak of inhibiting proteins, improves VQ match and oxygenation. There's improvements in asynchrony in terms of the thoraco-abdominal motion, and that is a reflection of improved pulmonary mechanics. CPAP also splints open the upper airways, which can have the effect of reducing resistance and preventing obstruction. Finally, if the mouth is open and there's some gas escaping, this results in some pharyngeal washout and reduced dead space. So there are many ways in which CPAP can be beneficial to preterm babies with RTS. So in clinical practice, CPAP was used variably after the report of Gregory and the development of the bubble system as well. What happened was that the ventilators improved and let's say the field of neonatology embraced mechanical ventilation. And in many cases, babies were electively ventilated if they were born preterm and showed any signs of RDS at all. However, there were some centers that, or at least one, that continued to advocate the use of early and prolonged CPAP, and that was Columbia Presbyterian in New York. This study was done by Mary Ellen Avery and published in 1987. She simply went around to 8 units and asked them to report their survival rates and their BPD rates in babies who were 700 to 1500 grams. And the BPD in this case was oxygen dependence at 28 days. But all of the centers had comparable survival rates, but the BPD rates were quite different. And Center 3, which was Columbia, had a much lower rate than the other sites. And one of the key components or elements of their clinical practice in terms of respiratory support was early and prolonged CPAP. And so this really was some indirect evidence that this may very well be the way to go to protect babies from lung injury. And so if we look at the beneficial effects of early CPAP, and I say the world according to one, and Gen 1, who was the strongest advocate of this, this approach to respiratory support, the first three, which we've sort of covered, but CPAP can facilitate lung inflation, maintenance of FRC, release or preservation of surfactant. And these all have benefits on the baby. But the other side effect of using CPAP is that you're not using mechanical ventilation. And so if you can avoid positive pressure ventilation, you will reduce baro and volute trauma, reduce pulmonary inflammatory response, which will then reduce the risk of BPD. And you will also avoid endotracheal intubation itself, which results in improved mucociliary clearance and reduction in the tendency to develop ventilator-associated pneumonia and infection, enhanced humidification, and elimination of instrumental dead space. So there are many benefits of using CPAP early and for a prolonged period of time, but he was sort of a voice in the wilderness for a period of time until some of the studies came online that supported the approach that they were following. The systems that we use for providing CPAP, I'll just cover quickly here. The two main ones, continuous flow CPAP systems. The bubble system I showed before is one of these, but you've got an oxygen-air mixture. Flow is delivered through an inspiratory limb. There's the interface to the baby. This is a very happy baby who's getting good respiratory support. And they draw whatever gas they need. Exhale gas goes into the expiratory limb, and the pressure is created in the expiratory limb. The variable flow system here, of which the infant flow is the best example. This is where the flow adjusts throughout the respiratory cycle and responds to differences in demand and also in with leaks in the system as well. So it's designed to help preserve the pressure in all circumstances. Both systems work well and have been shown to be effective, and comparative studies have not shown that one is clearly superior to the other. Now, for those of us who use CPAP, we know that there are some risks and complications associated with it. It's not easy to use. It requires excellent nursing care and constant vigilance. But firstly, it's not really a complication, but some babies who are placed on CPAP may in fact benefit from earlier invasive support if they have quite severe disease or they're quite tiny. So if you hang on too long, you might disadvantage them. Tendency to air leak, it's not very common, but some babies will get an air leak from the positive pressure that's being provided through the CPAP, especially high pressures. Gastric distension is common and can be very problematic. Increased irritability, where the babies do not like having this apparatus on their face and in their nose, and especially more late preterm babies and term babies really often don't tolerate it very well. There's a potential for impact on cardiac output, venous return, especially if pressures are high and compliance is good. And then at the bottom, you can see what we've all observed from time to time, which is a very serious complication of nasal pressure sores. Interfaces are important in terms of both the risk of complications as well as the effectiveness. Short binasal prongs, nasal masks are the most reliable for pressure transmission, and they have the lowest resistance. But short non-occlusive prongs with leaks, such as the RAM or high flow, do generate some positive pressure. But it's not reliable, and it can be inconsistent. There may also be some increased resistance to exhalation with these systems as the baby has to breathe against quite a high flow. And finally, there may be benefits in babies, especially if they have less severe degrees of lung disease, less nasal injury, and improved comfort. So there's a place for these short binasal prongs with leak for some babies. If we look at some evidence that's really looking at mask versus prongs, there were some studies, 8 studies that were examined in a systematic review, and babies treated with nasal masks versus prongs for the application of CPAP seemed to do better with respect to nasal CPAP treatment failure. And you can see here the summary statistic, relative risk of 0.72 in terms of treatment failure if you used a mask versus prong. And if you look at all the outcomes in the systematic review, they're shown here, they all trend towards improved outcome with the mask versus the prongs, but statistically significantly lower treatment failure and nasal injury if you use masks. So they do seem to be, in fact, a little bit better. Now, with that, I think we all know that masks can also cause some degree of injury, especially to the nasal bridge. And it's become common practice in many centers to alternate between prongs and the mask, which is a very reasonable approach to take. To explain why there might be an advantage of the mask, this is a bench study that was done that looked at the different interfaces at different flow rates and the resistance across them. And up at the top, you can see that the masks, there's virtually no resistance to flow across them, which you can imagine because of their shape. But as soon as you introduce prongs with a fixed smaller diameter, resistance starts to increase. And especially when you get into the smaller prongs and the ram cannula at higher flow rates, the resistance is really quite substantial. So this may very well explain why masks might work better. Clinical indications for CPAP in our population, and Roger will cover more of this in the next segment, but it's being used for initial respiratory support for babies at risk of RDS, neonates exhibiting signs of RDS, post-extubation support for babies with chronic pulmonary insufficiency, so the tinier babies who've been ventilated for a while but still need help for a long time. It may promote recovery and perhaps lung growth. And then finally, apnea prematurity, it's very effective there too. And it can also be used in bigger people. We know that it can be life-saving for people with sleep apnea, and we also know it can be marriage-saving. So summary and conclusions, CPAP does work well to mitigate the impact of RDS in preterm infants. It's been in use for a long time, over 50 years, and remains a key component of respiratory support for preterm infants to the present. CPAP systems are widely available and can be applied even in low resource settings, and we'll hear more about that later. And CPAP works through multiple mechanisms, and a number of variables impact on the effectiveness. So now we're moved to the evidence for CPAP from clinical trials, and I'll hand over to my colleague Roger Soll to cover this. Thank you for your attention.
We're going to do a little pause before we turn it over to Roger. Mike, thank you so much for that excellent synopsis of how CPAP works. We now have almost 800 people joining from all over the world, and I'm curious to learn about how CPAP is being used in our NICUs. Are our team members using it prophylactically for treatments, combination? They're not sure. That's why you're joining today. Or we might have some team members joining and they're not yet using CPAP. So I'll give a moment to see how these numbers are coming in. And it looks like in maybe about a quarter of the settings, mostly based on symptoms, using it for treatment, and about 3/4 a combination, both prophylaxis and treatment. So that sets us up nicely to turn it over to Professor Roger Soll, and he's going to review some of the evidence that informs both our practice and the recommendations that that's based on.
Thanks, Danielle. I'd like to take the opportunity to discuss some of the newer recommendations regarding the use of CPAP worldwide that were put out by the World Health Organization. Specifically, the recommendation that CPAP be used immediately after birth in infants less than 32 weeks gestation, and a recommendation that using bubble CPAP as your CPAP source is a very reasonable and supportable approach to using CPAP. So let's take the time to look at the evidence from randomized controlled trials. I'm going to focus on 4 reviews from Cochrane Neonatal. The first is the use of continuous positive airway pressure for infants with respiratory distress syndrome. The second review is the prophylactic or very early initiation of continuous positive airway pressure in at-risk preterm infants. The third review reflects the question of the exact source of pressure and compares bubble devices to other pressure sources for continuous positive airway pressure. And lastly, I'd like to touch upon the randomized controlled trials that looked at the timing of surfactant, which is heavily influenced by our wishes to maintain infants on non-invasive ventilator support, and how time has affected our appreciation of that. So let's start with some of the core trials of CPAP, the trials of CPAP for infants with respiratory distress syndrome. In this trial, the authors looked at the effect of continuous distending pressure in the form of CPAP on the need for intermittent positive pressure ventilation and other associated abnormalities in infants who are spontaneously breathing with respiratory distress syndrome. They didn't find a lot of data. There are 5 studies with very few infants, 322 infants, and the studies themselves are fairly eclectic. 2 studies used face mask CPAP, 2 studies used nasal CPAP, and 1 study used an endotracheal tube for CPAP. 4 studies were conducted in high-income settings, and 1 trial was conducted in a lower resource setting. And there's a broad span that these trials were conducted under. The results are generally very positive regarding the use of CPAP in these infants with respiratory distress syndrome. There is a profound decrease in the treatment failure and the need for mechanical ventilation. If we look at the relative risk, we see a 36% difference in risk, which translates to a risk difference of around minus 19%, suggesting that for every 5 infants that we treat with continuous positive airway pressure, we'll have 1 less treatment failure or need for mechanical ventilation. There's less use of assisted ventilation, and there's less mortality. A very profound difference in mortality was reported in these studies, suggesting that for almost every 9 or 10 infants we support on CPAP, we have 1 fewer infant who dies. That said, there were some harms that were reported. You can see here that there was an increase in the risk of pneumothorax that was quite substantial, with a almost 2.5-fold increase in the risk and a risk difference of 9%, suggesting that for every 11 babies who are treated, we might see 1 more pneumothorax. Remember, that wasn't translated into a difference in BPD or mortality. So the authors conclude that in preterm infants with respiratory distress, the application of CPAP is associated with reduced respiratory failure, reduced use of mechanical ventilation, and mortality, but an increased risk of pneumothorax. We'll talk a little bit about how heterogeneous these trials are a little bit later in this session, but the authors do suggest that further studies in low and middle income countries should be considered. So let's take a look at the use of prophylactic or very early initiation of continuous positive airway pressure in preterm infants who are at risk of respiratory distress syndrome. There were 8 trials involving over 3,000 infants, so we have somewhat more evidence to address this question. The authors want to determine if prophylactic nasal CPAP started within the first 15 minutes of life, or very early nasal CPAP, regardless of the infant's respiratory status, that was started within the first hour of life, reduced the use of mechanical ventilation, BPD, and other adverse effects associated with preterm birth. They included 8 studies, recruiting over 3,000 infants. 4 trials involving 765 infants compared CPAP with supportive care, and 3 trials compared CPAP with mechanical ventilation. Specifically, when we take a look at the trials of prophylactic or very early initiation of CPAP compared to supportive care, we see that there is a profound decrease in treatment failure or the need for mechanical ventilation, and specifically a decrease in the need for assisted ventilation. 4 trials addressed treatment failure, and they showed a 40% decrease in the risk of treatment failure, which was a 16% risk difference, suggesting that for every 6 infants who we place on prophylactic or very early CPAP, we see 1 less treatment failure, and we see a 27% decrease specifically in the use of assisted ventilation, which translated to an approximately 8 or 9 number needed to treat. The authors conclude that there is not sufficient evidence when it comes to evaluate prophylactic CPAP compared to other supportive care, but they see that in fact it is better than mechanical ventilation. Let's take a look at the issue that was addressed to the WHO regarding bubble devices versus other sources of pressure. There are a fair number of trials that address this, but really not that many infants, so many small trials, 15 trials involving 1,437 infants. They want to assess the benefits and harms of bubble CPAP versus other pressure sources, which included mechanical ventilation or infant flow drivers. And they looked at preventing treatment failure and other associated morbidity and mortality associated with preterm birth and respiratory distress. They included 15 trials involving 1,437 infants, and the trials took place over a broad period of time and in centers that were quite far-flung and international. What they found was that there was a decrease in treatment failure associated with using the simpler bubble CPAP devices. It's a marginal difference, around a 24% difference in risk, but it could be as little as a 5% difference in risk. And the risk difference suggests that it could be from minus 10% to minus 1%. So it could be as few as 10 infants treated with bubble CPAP who wind up with fewer treatment failures, but it could be as many as 100. It did not find other differences in mortality, pneumothorax, nasal injury, or BPD. Towards that end, they felt that there's really a low level of certainty regarding the preferred device, but that one might choose bubble CPAP and that further trials might be warranted. So let's step back for a second from these trials and these reviews. And one thing that I think is notable is that these trials were done in many different settings over a very large period of time. And it brings up the question, is there an expiration date for clinical trials? Is this data still useful for us? And my answer is going to be, it depends. Let's go look back at the very first review I discussed, the review of continuous positive airway pressure in infants with respiratory distress syndrome. If we take a look at the years these trials were conducted, they were conducted from 1973 all the way through 2020. The numbers in these trials are relatively small, and the birth weights included are somewhat larger than we might be treating today. The sources of CPAP were fairly heterogeneous, everything from mask CPAP to nasal CPAP. But importantly, when we take a look at these populations over time, we realize that they may or may not be referable to the current populations we're treating. Just for example, in the Buckmaster study of 2007, only 35% of the infants who were enrolled received antenatal steroids. And when we take a look at the study from 2020, we see that the babies are somewhat larger than the babies that we might be concerned about, with a median gestation of around 33 weeks and birth weights ranging from 1,000 to 1,800 grams. Again, even in this more recent study, only 39% of these infants received antenatal steroids. So why is that of concern? Well, let's take a look at the trial that compares the use of prophylactic surfactant to selective use of surfactant, remembering that in the selective use of surfactant, these babies are not intubated or necessarily placed on any respiratory support. When we look at the early trials done throughout the 1990s, we can see that there was a strong signal towards preferring prophylactic surfactant to more selective treatment. Here in the meta-analysis of those studies, we see a large difference in the risk of death of around 31%, and the confidence interval is fairly tight. But when we move forward and we look at the studies done in a more recent context, specifically the support trial from the NICHD and our VON trial by Mike Dunn, we can see that the results move us in the opposite direction. These are studies that were done in an entirely different context, with frequent use of antenatal steroids and with support for the infants who were not intubated and given surfactant on nasal CPAP. And we see that the results are quite disparate. And when we compare the two, they move us in totally different directions and with different decisions. So in this case, it truly matters. But I would argue it's not just a matter of time. It's a matter of understanding how the context changes. So for example, many of these trials that might be done in situations where antenatal steroids were not given and where bigger babies are treated, this data may be quite applicable to practice. If not, we need to rethink it as well. So on that point, I'll turn it back over to you, Danielle.
Thank you so much, Professor Soll, for reviewing the evidence from randomized controlled trials on CPAP for RDS and challenging us to think about the context of care in which this research was completed. The care of the small and sick newborn, the preterm infant with RDS, is one of the most pressing issues globally. The burden is immense, with 13.4 million babies born preterm every year, and a country preterm birth rate ranging from 4 to 16% of births. We know that currently, complications of preterm birth are the leading cause of death, not just amongst newborns, but among all children under 5 years of age. In just the year 2019, deaths of infants born preterm totaled 900,000. To emphasize translating evidence to practice, we also know that approximately 75% of these deaths could be prevented with current cost-effective interventions. Professor Lulu Muhe and colleagues did an elegant study in Ethiopia to determine why preterm infants admitted to NICUs were dying through autopsy and expert case review. They found that RDS was the #1 primary cause of death, accounting for 45% of the preterm deaths across 5 Ethiopian tertiary NICUs. Professor Dunn has shared how CPAP works, and Professor Soll has provided an evidence update. For the treatment of RDS, we know that CPAP is a superior treatment compared to supplemental oxygen for RDS, with the number needed to treat to benefit of 6, meaning that for every 6 infants treated with CPAP instead of supplemental oxygen, 1 less infant has the outcome of death or use of mechanical ventilation. The confidence interval shows us the certainty of this data. It could mean treating as many as 11 to have this benefit, or treating as few as 4 to avoid 1 death or use of mechanical ventilator if available. As we think along the spectrum of implementation, we have seen compelling efficacy data in tightly controlled randomized trials. For effectiveness, what does this mean in the so-called real-world conditions and LMIC context outside of RCTs? Our colleagues in South Africa assessed effectiveness of interventions for preterm infants with RDS. In their context, availability of CPAP reduced the mortality rate by 50%, supporting their conclusion that it is the foundation in the treatment of preterm infants. Based on the accumulation of evidence and experience, the recently published World Health Organization recommendations of the care of the preterm or low birth weight infant from November 2022 provided an updated and strong recommendation based on moderate certainty evidence that CPAP therapy is recommended in preterm infants with clinical signs of RDS. This was accompanied by 2 new but conditional recommendations based on lower certainty evidence that CPAP therapy may be considered immediately after birth for very preterm infants with or without respiratory distress, and regarding the pressure source, that for preterm infants who need CPAP therapy, bubble CPAP may be considered rather than other pressure sources. The global recommendations that CPAP therapy is recommended in preterm infants with clinical signs of RDS have also been translated into national and subnational targets. The Every Newborn Action Plan has set targets that by 2025, 80% of countries will have a national implementation plan for the small and sick newborn that is being implemented in at least half the country. Within countries, the national and subnational targets are that 80% of districts within a country have at least 1 level 2 inpatient unit to care for small and sick newborns with CPAP. These global, national, and subnational targets have challenged us to think along the research framework spectrum about how to integrate or better integrate CPAP into practice within a system. The efficacy studies have shown us that CPAP works compared to supplemental oxygen. The ongoing effectiveness and pragmatic studies are helping us to understand how it works better or best, taking context and real-world conditions into consideration, viewing CPAP as one important element in a package or bundle of preterm care. In order to reach the implementation targets and neonatal mortality reduction goals, focusing on implementation science and dissemination will remain critical. How do we as a global community facilitate thoughtful uptake in various settings and contexts? Professor Dunn has shown us that CPAP is intensive care, and providing continuous quality care and quality continuous positive airway pressure can be complex. Availability of CPAP devices is necessary, but not sufficient for improved care and outcomes. Devices and drugs alone do not save babies. Healthcare teams using these devices and drugs thoughtfully and properly save babies. Similar to how we view the rights of medication use, there are rights for CPAP use in respiratory distress syndrome. And instead of 5, there are probably at least 7. We still need the right patient, the right drug. We want to optimize CPAP before escalating to additional treatments like surfactant. the right dose, optimizing CPAP pressure and minimizing FiO2 using target saturations, the right route using short binasal prongs or nasal masks, the right time aligned with those WHO recommendations, treatment based on clinical signs of RDS, or considering prophylactic treatment for very preterm infants less than 32 weeks. And I can't emphasize the last two enough. The right team, an educated and empowered multidisciplinary team working together. The right place, at a macro level, are level 2 to 3 inpatient neonatal units serving their districts in regional or national catchment areas, and at the micro level, ensuring and encouraging CPAP to be administered while infants are skin to skin and in KMC. In summary, we know quite a bit about how many babies are dying, where babies are dying, why preterm babies are dying, and what interventions are effective. The Utstein formula for survival, often thought about in resuscitation care, emphasizes 3 main factors for survival: medical science, educational efficiency, and local implementation. All 3 need to be perfect for 100% survival. This equation is appropriate in the case of preventable deaths of preterm infants with RDS as well. Our medical science is pretty good. It might not be the utopia 100%, but it's excellent, perhaps in the 80 to 90% range. Our educational efficiency, and especially education targeted for the context of care in which it is provided, is improving, likely thanks to many colleagues joining in on this session today. However, we still have room for improvement. We might rate this at about 50%. Lastly, the local implementation component is an area that many are working on, but is incredibly variable. We need continued shared stories of successes and challenges as we think of these 3 factors needing to work together to save preterm newborns and our shared responsibility to our global community. Today, it's my pleasure to put the spotlight on Dr. Malet Abena and work she has led on local implementation in Ethiopia. Thank you so much, Dr. Malet, for sharing with us today.
Thank you, Daniel, for this opportunity. Good morning, good afternoon, everyone. I am Mahalit Abena, Associate Professor at St. Paul Hospital, Millennium Medical College, and Newborn Technical Working Group for Ethiopian Federal Ministry of Health. I'm co-investigator in Ethiopian National Need for African Neonatal Network. So to give you a highlight about neonatal mortality in Ethiopia, based on our 2019 Ethiopian mini demographical survey, there are 33 neonatal deaths per 1,000 live births, which was around 39 per 1,000 live births in 2005. We're not showing significant improvement or progress towards neonatal mortality for the last more than 10 years, but we have shown significant improvement in the under 5 mortality and infant mortality. Despite a lot of efforts to reduce neonatal mortality, we are not seeing much change in the numbers, and also there are higher mortality rates. So when we compare preterm mortality in Ethiopia and United States, there are higher preterm mortality based on gestational age for babies at different gestational age. For example, if we see the 28 weeks, less than 28 weekers, 86% of them are dying in Ethiopia as compared to 38% in US. And also you can see the comparison for all the gestational age. So to take you through the neonatal network, Ethiopian Neonatal Network is established by the collaborative effort of VERMONT Oxford Network and Ethiopian Pediatric Society. The Ethiopian Pediatric Society has pediatricians and neonatal nurses, pediatric nurses as a member. And the Ethiopian Neonatal Network is established for those hospitals which have different levels of neonatal intensive care unit. Could be tertiary hospital, or referral hospital, or general hospitals and district hospital. There are 20 member hospitals under this network. The main purpose of the neonatal network is to create a communication among the NICU so that they learn from each other, and to create also a means for quality improvement through data utilization. And members are expected to do quality improvement work, share their activities, and also do database and see what has happened to the unit as in their like mortality and morbidity of newborns generally. So this member hospital, we used to do twice per year annual meeting, especially before the COVID era, and member hospitals discuss and present their quality improvement work that they were doing throughout the year. Initially, when we start the ENN, Ethiopian Neonatal Network, there was training on quality improvement provided with VERMONT Expert Network volunteers and also by Ethiopian Pediatric Society. And then after they took the training, everyone went to his hospital or her hospital and did the quality improvement for neonatal intensive care unit. And that was being shared during the face-to-face meeting of Ethiopian Neonatal Network. And in 2020, the teams gathered during the COVID era. As you see, everybody is on mask. And there was a question, like the problem was defined, like there is high mortality rate among all NICUs in the member groups. So there were like, the why questions were raised. Why are preterm newborns are dying in our unit? And there were like a lot of issues discussed. The issues were reclassified into 6 major groups, like supplies, policy, people, environment, equipment, and process. And using the fishbone analysis, the problems that were listed were reclassified either to one of the 6 major identified problems. So the team were requested to choose which one is the leading area that they want to improve to decrease neonatal or preterm neonatal mortality in their unit. And most of the team selected CPAP. The hypothesis provided was, as you remember, this was a COVID era, then face-to-face teaching was difficult. So a 12-month web-based QI collaborative with telementoring and remote CPAP pre-pressure training will be an effective means of providing education, technical advice, professional support during a period with necessary limited travel and group activities was the initial hypothesis that we have. So the main thing that was delivered during the CPAP telementoring was the national guideline for initiation of CPAP. This national guideline was prepared while the country has distributed the CPAP machines, the Diamedica CPAP machines for 80 hospitals. And this guideline was prepared by the collaborative effort of BON, UNICEF, and Ministry of Health. And it incorporates who to start on CPAP and how to follow a patient who is started on CPAP. So as you know, in low middle income countries, defining RDS is a problem, and also like deciding who has severe RDS and who has mild respiratory distress syndrome and moderate RDS is a problem because we don't have access for blood gas, and also X-rays are not available here and there. So the team has developed this clinical assessment using Down score, and it was objective evaluation for respiratory distress, and babies will be scored from like 0 to 3, which will be labeled as mild or no distress, and 4 to 7 moderate, and 8 to 10 as severe. So this was one of the things that was included in the education during the telementoring. And we have found also good concordance among physicians and nurses while doing Down score. And the other is, how do we monitor babies on CPAP? Like, what are the things that we need to do continuously monitor? How frequently we have to monitor and record vital sign? So it has a monitoring part. And when a baby is on CPAP and has worsening, or when a nurse is following a baby on CPAP, what are the things that she has to check every 2 to 4 hourly? That was labeled as CPAP safety checklist. So this algorithm was one of the areas that was intensely covered by the coaches, for their Menti hospital. So when to start CPAP, the signs of respiratory distress with Down score of more than or equal to 4, or if the baby has oxygen requirement of more than 30% to maintain his saturation, more than 90%, and the other is like if we decide to start the baby on CPAP, with what parameter do we start? So baby could improve or could worsen. What are the signs of improvement? If the baby is improving, how do we win from CPAP? And if the baby has worsening signs, what are those worsening signs? When do we say the baby has worsened? So if the baby has worsened, what do? We do the CPAP safety check and also look for complications like pneumothorax, and considering optimizing the CPAP using different prongs which are wider, like the Addison was included in this algorithm. So this was one of the areas that was covered by the coaches during the CPAP telementoring. So SMART aims were developed. So the SMART aims were like by September 30, 2022, like 10 months after the initiation of the CPAP collaborative, one of the SMART aims was increase the percent of NICU staff, nurses and physicians trained on CPAP from 35% to 90%. And the second SMART aim was increase the percent of NICU utilizing standard vital sign sheet for infants on respiratory distress from 40 to 75%. And the third was increase the percent of patients with presumed RDS with Down score documented on admission to 90%. So, and the fourth is increase percent of patients with presumed RDS and Down score 4 or greater treated with CPAP to 90%. These were the SMART aims that were taken into consideration to improve. So we do a monthly meeting with the coaches and faculty. And during this monthly meeting, the run charts were presented for those SMART aims that we have discussed earlier. So, and for every hospital, there will be every 2 months meeting, and they will also get the feedback on their activities. So these are the findings from the run charts. For example, percentage of nurses trained on CPAP, total number was 385. Initially, it was around 26%. So throughout the course of 10 months, it has improved to around 77%. And the median has also improved from around 62% from around 33%. And doctors trained on CPAP were total 66. And it has also improved from 40% to around 72%. And when we see the workload of the coaches and the mentors, a total of 659 staff were trained overall. The first bar graph is for the nurses trained per hospital. Like around 5 hospitals have all their nurses, 100% of their nurses trained. The problem was attrition. There is high turnover of nurses in the unit. So there is rotation that is being done for the nurses. And among the trained staff, 208 trained staff left and 380 new staffs had needed training. So this was the main challenge during the training that was faced by the coaches and the mentors. So the total number of nurses and physicians trained across all sites were around 75%. So the other thing that was also improved significantly during the telementoring was the vital sign sheet, proper vital sign sheet. So there was no proper practice of vital sign recording for babies on CPAP. Some centers do every 6 hourly, some centers 4 hourly, some centers twice per day. And the vital sign record for CPAP and oxygen was developed and shared among the team. Orientation was given during the telementoring. And initially, utilization of this vital sign sheet was around 43% and has progressively increased to 86%. And the other thing that was also being practiced was performing down score at admission. So even if down score was performed, sometimes it was not documented. So we have seen like initially it was around 98%. It was almost similar throughout the course with same median during the telementoring. And the other is patients treated with CPAP. When we say CPAP, there are two types of CPAP, the locally made and the machine CPAP, which are the bebés CPAP. So the locally made CPAP initially was using this narrow tubings, which we use for low flow oxygen administration. And the machine CPAP is, as I have told you, most of the centers, almost all of the centers have Diamedica CPAP machine. So initially, the number of babies who were started, whether it is locally made or Diamedica CPAP, was around 83. And on May and around after 8 months after we start the telementoring, how to improve the locally made CPAP was one of the trainings that was provided. Like, how do we make it optimal? How do we make it effective? By using wider tubes, wider nasal prong, and the like was also included in the training. And after that, there was some improvement on the utilization of this CPAP for moderate to severe RDS treated with CPAP. So the other outputs that this telementoring has delivered was using the development of the objective structured clinical examination tool. And it was prepared, improved several times, and now it is being used for on-site mentors, and it is used by the coaches, and it is being used for assessment and learning tool for any other student. And it can be used also for initial training and refresher training. So you just observe and then give feedback for the training. This was the other outputs that we have. So what do we learn from the telementoring? What are the take-home points? Telementoring and remote training was successful, and 21 teams has completed remote CPAP training with one on-site visit. One on-site visit was possible, and the adoption of down score and vital sign was very good. And continuing professional development credits are appreciated by the team because they have also received CPD points after they have completed the course. And the provision of quality CPAP is a skill set. So ANN has amazing nurse and physician mentors. So on top of the telementoring, hands-on mentoring component is important and it's beneficiary. CPAP is critical care for small and sick newborns. We have to improve nurse to patient ratio. Vital signs should be monitored frequently, and there need to be specialized trained team to provide babies, follow babies, to decide babies on CPAP. And training is not equivalent to capacity building. The most important thing that we learn is retention of staff is mandatory. Like, we have trained a lot of staff, but there is 32% attrition. So even if they were trained, they were not working in the NICU. So time to build upon success of improved process. The other is CPAP equipment and accessories are major limiting factor for implementing education and realizing the potentials of mentorship. These were the challenge that was reported by the team repeatedly, like the CPAP accessories need to be replaced as they get damaged. Thank you for joining us today. If you have any questions, you can forward. We're pleased to give our comments or suggestions on that.
Thank you so much, Dr. Mahalet. So now we've reviewed some evidence to practice in a whirlwind tour, and I really appreciate the excellent quality work that you've highlighted on behalf of our colleagues and multidisciplinary teams in the Ethiopian Neonatal Network, represented in this beautiful photo. So reflecting on some of the key aspects of implementation, I'd love to hear from the audience about maybe the most important opportunity you feel like there is to improve CPAP in your NICU. So this is another poll everywhere question. Looking at the chat, maybe educating the healthcare team onto how to properly feed patients while using CPAP would be a good option there. looks like the empowering the multidisciplinary team is a big factor, educating the healthcare team. Those two, go hand in hand. There's still opportunity for more innovation with our devices and our interfaces. So always a lot of opportunities for improvement with CPAP. And I thank everyone for their thoughts on some of the key aspects that are represented by our audience today. So today we have reviewed evidence from efficacy through effectiveness into implementation. And I think we're reminded how important it is to consider implementation from the outset. Even pilot implementation data are some pragmatic real-world aspects informing the earlier phases of this work. And I wish we had more time for our faculty, but we do have, I think, 5 minutes left for some Q&A. So I'll ask our other faculty members to turn their videos back on. There they are. And I maybe have a few rapid fire questions, but if you have others that you've seen in the chat that you think are must answers, we can get those as well. So I'll first ask Dr. Soll. It was a great evidence review. Thank you so much. And I'm curious where you think the evidence is taking us, and maybe especially for that aspect of less than 32 weeks. Do we have more evidence that's needed, or do you think we should be a bit pragmatic about deciding who needs to be treated?
Well, I certainly think that the evidence that exists can extend to a pretty broad range of gestational ages and can be extrapolated in a pragmatic way. There was one question in the chat, though, that reflected, what are we really doing at the extremes of prematurity? And that's an open question, well worth further study. And people jump to either, oh, it'll apply to everyone, or now we still have to intubate all of those babies. And that's a very valid clinical question.
Thank you. Professor Dunn, I'm curious if you'd like to make some comments about best practices. You had a wonderful review about how CPAP works, and now we're all thinking about, well, how does it work best? And maybe you have some pearls of wisdom about optimizing CPAP to share with us, or some key factors.
Sure, thanks, Danielle. I don't think they're pearls necessarily, mostly covered. But you do need an effective system, and all of the components are important, including some of the things that were mentioned in the chat as well. You have to have gas source, you have to have blender, you have to have proper interfaces, you have to have a method of generating pressure, and you have to have personnel who can apply it effectively. And we touched on it, but the importance of good nursing care can't be overestimated. And that does present a problem in a place like Ethiopia and low resource countries where, sometimes the ratios of nursing to baby are so high, or baby to nurse. And so I think this is a real problem. And, one thing in terms of the actual interface, we talked about it a bit, but you do have the choice of using either masks, tight fitting binasal prongs, or the smaller prongs with leak like the RAM cannula. And each has its advantages, disadvantages. Certainly, when we had to look at implementing CPAP in Ethiopia, we actually chose to go with the RAM because of the problems with the nursing ratios and the tendency to have a lot of nasal injury if you could not keep an eye on the baby very, very carefully. So I just wanted to ask Mollett too, within that sort of theme, how do you address the difficulties with nursing care in terms of optimizing CPAP and ensuring minimal injury? And I also wonder about the role of parents in the place of skin to skin, which is also a big part of the WHO guidelines that have just been released as well.
Thank you, Mike. So how we manage the nursing to patient ratio, we know we have a lot of patients, but the number of nurses is not always proportional. So what we did is if a nurse has a patient who is critical and on CPAP, we reduce the number of patients that nurse will have in that day. So she will give more attention for those. So we don't give evenly the number of patients. So we decrease the number of patients that are on CPAP for the nurse. So the nurse to patient ratio, we have put a standard for the nurse to patient ratio. For if a nurse has to care a baby on CPAP, we will make the ratio to like 2 to 3 patients per day. So the feeding, checking of like if the abdomen is distended, checking the nares, and checking whether the CPAP is working, like if the tubes are disconnected and the like, takes some time of the nurses. So this is done by this thing. And the other most important thing that helped us is the education, the teaching has significant role. So as it has been said, empowering the staff is most important. So that is the other support that we have. I would like to say thank you everyone who is involved in the teaching, and also the coaches and the development of the guideline.
Thank you, Dr. Millett, for sharing those lessons with us and having such a wonderful example about how you did it. You changed the culture in your unit. You've implemented a tool where there's a shared language between physicians and nurses and empowered your team. And I think many joining in today appreciated learning from you. And I hate to cut us short, but we are at the top of the hour. I see a lot of amazing questions and requests coming into the chat. So we'll make sure that the faculty have a chance. We'll copy that and take a look at that as we follow up. And I hope everyone who joined in today will come back. Our next grand rounds will be in September as the team reviews the evidence to practice on preventing intraventricular hemorrhage. So thank you very much today, and we'll have the recording on the website in about a week. Thank you.
Bye, everyone.
Bye, and thank you.